All right, so welcome everybody to Grand Rounds for today, the Family Medicine Grand Rounds for August 24th. For those interested in CME credit, please take note here of the event ID code that you will need. It's kind of hard to see there, but please just make sure that if you want to claim the credit that you do so before midnight tonight. I will go over some additional instructions for those who may be new to the system here in the next slide. Can you move it forward for me? There we go. Thank you. So for those who are new to the system, if you have not yet registered, please just send your email address to the number listed there, the toll-free number. Once you've done that, from that point forward, you just need to text attend, and then today's session number is listed there for you. You would send that to that same toll-free number. But if you're having any issues with that, please feel free to reach out to me. I can put my email address there in the chat once we get started here, and happy to help with that. So next slide. As we get started, if you could make sure that your microphone is muted as we begin the presentation. Also, if you can just remain attentive and engaged in the session. Towards the end of the presentation, I will be putting in a link for us to provide feedback to our speakers. We really need your help with that. So if you could please help us provide the feedback. I will also email the link out later today. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC. Our department's mission statement is there for you to take a look. Next slide. And again, going back to CME, if you are claiming the credit, make sure that you do check every so often your transcript, which is located at the UTESCA CME office website. But if you have any issues, please feel free to reach out to them, or you can reach out to myself as well. Next slide. And then also, we just want to point out that you can receive credit through the AAF system as well if you are a member. So please keep that in mind. But if you have any questions, their information is listed there, or you can reach out to me as well. Next slide. We also want to mention that our grand rounds, the goal is to make sure that we address these nationally established physician core competencies that you see listed here. Next slide. And with that, we just want to also mention that Dr. Candelario, Dr. Walker, and their faculty mentor, Dr. Palacios, have no financial relationships with eligible companies to disclose. Next slide. So they're going to present to us today. The title of their talk is SGLT2 inhibitors and GLP-1 receptor antagonists reduce all-cause mortality amongst other patient benefits. So I will let them take it from here.
Hi there. So my name is Rachel Walker. I am a third-year resident here in San Antonio, and my co-presenter is Dr. Candelario. He is also a third-year family medicine resident, and Dr. Palacios is our faculty mentor for this presentation. Next. The objectives for today is we're going to summarize the pharmacology of available GLP-1 receptor agonists and SGLT2 inhibitors. We're going to analyze two different meta-analyses with evaluating the effect of SGLT2 inhibitors and GLP-1 receptor agonists on patient outcomes and patient mortalities. And we're going to promote the increased use of SGLT2 inhibitors and GLP-1 receptor agonists in the primary care setting. Next. So today we're going to talk about two questions of concern. We're going to be going over two poems, two AAFP poems, which are patient-oriented evidence that matters. The first poem is going to address this question: do SGLT2 inhibitors or GLP-1 receptor agonists reduce patient-oriented outcomes in patients with type 2 diabetes mellitus? And the second poem is going to address the question, what effect do SGLT2 inhibitors have on mortality in cardiovascular and renal outcomes in patients with and without diabetes, heart failure, or kidney disease. Next.
So hi, everyone. I'm Etney, one of the residents here, as Rachel mentioned. So I'm going to start off by giving a bit of background on GLP-1 receptor agonists. So the glucagon-like peptide 1 agonist is a 30 to 31 amino acid long peptide hormone or incretin. It's mainly secreted in 3 tissues in the human body: the distal intestine, alpha cells in the pancreas, and the central nervous system. Once released, the GLP-1 has a relatively short life, about 1 to 2 minutes, for one main reason, and that's the dipeptidyl peptidase, or DPP4, which cleaves the GLP-1 into its less active form. So in type 2 diabetes, GLP-1 agonist response is significantly reduced. So it's hypothesized that this contributes to the pathogenesis of diabetes. And when GLP-1 receptor is activated in the pancreas, it triggers a CMP-PK pathway. Insulin is synthesized, secreted, and beta cells start to grow, resulting in lower blood pressure or lower blood glucose. It's also known to have many other benefits, not just in the GI or GI endocrine system, but it also has, it's not only found in the pancreas, it's also found throughout the GI, the heart, the brain, the liver. And due to its wide distribution in the body, there's other effects besides just lowering the blood glucose, which we'll talk further on in this presentation. It also decreases satiety, or increases satiety, and slows down gastric emptying. So as primary care physicians, who should we consider starting a GLP-1 receptor agonist? Per the American Diabetes Association, metformin still remains the preferred first-line treatment for treating type 2 diabetes. But GLP-1 should be considered in certain diabetic patients. Those that have tried metformin and were unable to tolerate it, we know metformin can cause upset stomach or other GI symptoms. You should also consider starting a GLP-1 receptor agonist in those that have an A1C greater than their target by 1.5%, and those with an A1C that have not reached their target goal within 3 months. Additionally, you should closely consider GLP-1 if the patient has a history of atherosclerosis, heart failure, or chronic kidney disease. GLP-1 agonists are also known to decrease weight loss or increase weight loss. There's high dose liraglutide is the only FDA-approved GLP-1 treatment for obesity, and can be prescribed to patients that are overweight and have comorbidities. And I wanted to briefly mention some of the possible barriers that we may face when prescribing GLP-1 agonists. First is its high cost. These medications tend to be very expensive. For example, Victoza, out of pocket, it's usually around $1,300 for 3 pens. And another barrier might be tolerability. Most frequently exhibited side effects from this class of medication is nausea, vomiting, and diarrhea. So GLP-1 receptor agonists are contraindicated in patients with a personal or family history of medullary thyroid cancer, or in patients with multiple endocrine neoplasia syndrome type 2. There's two exceptions. You can use exenatide and also lixisenatide in people with a personal or family history. I should be careful with exenatide. It shouldn't be used in patients with chronic kidney disease with the creatinine clearance less than 30 or end-stage renal disease. And you should also use GLP receptor agonists cautiously in patients with gastroparesis, severe GERD, or an inflammatory bowel disease, as GLP-1 to slow down the gastric emptying, so they can worsen these illnesses. So as of 2021, there were 7 approved GLP-1 receptor agonists. As you can see in table 1, there's Byetta, which is twice daily, Lexumia, which is once daily, Victoza, once weekly or once daily, Bydureon is once weekly, and Trulicity is once weekly, and Ozempic is once weekly. And the newest one approved in 2019 is the Rybelsus, which is the first PO one, and it's usually once daily as well. There's been GLP-1 head-to-head clinical studies that have demonstrated that all GLP receptor agonists are all effective in reducing A1C and weight. However, each differ in the magnitude that they decrease the A1C or weight. They also differ in the frequency of adverse effects. So something to consider when choosing a GLP-1 agonist. Some patients may not want another injection. So in that case, you could consider using a PO GLP-1 agonist, or if the patient cannot tolerate a specific GLP-1 agonist due to like a known GI effect, you can consider switching to one that has a lesser adverse risk with less symptoms, or less known to have symptoms. In addition, there are also 2 basal insulin and GLP-1 receptor agonist combination. In the US, there's the Shutofi and the Soliq, which makes it convenient for patients to just have one single injection instead of 2. Also something to consider if the patient is already on a basal insulin and a GLP, you could combine it and make it less burdensome for the patient.
So moving on to some pharmacology of SGLT2 inhibitors. These are your medications that end with flozin. Sodium glucose cotransporter 2 proteins. Those are expressed in the proximal convoluted tubule of the kidney. They are responsible for about 90% of the filtered glucose reabsorption. So inhibiting these receptors, what it's going to do, it's going to reduce the renal tubular glucose reabsorption, which increases the urinary glucose excretion, ultimately with the effect of lowering serum glucose. This is important because this is independent of beta cell function and insulin secretion. So this is a good idea in patients with long-standing type 2 diabetics. And because of this mechanism of action, these medications on their own usually don't cause hypoglycemia. Next. This slide is about patients we consider using SGLT2 inhibitor use in, and I will say this will broaden after we talk about our poem here in a little bit, but generally you're going to consider it in type 2 diabetics, particularly those that are overweight, hypertensive, unwilling or unable to use injectables because all of the SGLT2 inhibitors are PO, at patients with high risk for hypoglycemia, because just like I mentioned, these drugs on their own typically don't cause hypoglycemia based on their mechanism of action. Good for patients with long-standing diabetes, patients with heart failure or atherosclerotic cardiovascular disease, and patients with a GFR less than 90 but greater than 45. Next. Here we have a chart of available SGLT2 inhibitors right now. As you can see on the left, you have their generic names, brand names. There's 4 of them. You have canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. They're brand names which are much simpler to say. These are all PO, and you do take them in the morning. And then, like Etney mentioned, some of his combination medications. Down here, we have our SGLT2 inhibitor combinations. And you'll see the first 3 are with metformin, and then the last one is with linagliptin, which is a DPP4 inhibitor. I think it is important that not only are we familiar with the individual drugs, but the combination drugs, because pill burden is important. You know, reducing pill burden is important for our patients. Next. Contraindications for SGLT2 inhibitor use. We do not use these in type 1 diabetics. Class-wide, if you have a GFR less than 30, you are not going to use this medication. But more specifically, if you have a eGFR less than 45, you're not going to use dapagliflozin or ertugliflozin. And then you're not going to want to use these meds in patients with previous DKA. You're going to use these medications or use them with caution or avoid them with the following patients, and you'll see why when I explain the risks and side effect profile. But patients with frequent UTIs or genitourinary yeast infections, low bone mineral density or high risk for falls, and foot ulceration. Next. Common adverse effects of SGLT2 inhibitors. First one being genitourinary tract infection. This is because of the mechanism of action that we explained, that you have an increased concentration of glucose in the urine. And the FDA warns that there's an increased risk of urosepsis, pyelonephritis, and necrotizing fasciitis of the perineum, also known as Fournier's gangrene. You have a risk of hypotension and AKI. The thought behind that is that you're gonna, with the increased glucose in the urine, you're gonna have an osmotic diuresis. And so be very cautious when you're starting these medications on patients who are already on diuretics or on ACEs and ARBs. You just need to be mindful of that. In regards to the risk of bone fracture, they believe there's a connection between symptomatic hypotension resulting in increased falls, thus resulting in increased risk for bone fracture. You have an increased risk for DKA. In particular with these medications, there's a risk for euglycemic DKA, which is important to be mindful of, especially when you're in the hospital or the emergency department. And you have an increased risk of amputations. And from what I understand, that risk was shown with canagliflozin on 2 randomized controlled trials. Next.
Okay, so as Rachel mentioned, this is one of our poem clinical questions. So do SGLT2 inhibitors or GLP-1 receptor agonists, do these medications reduce patient-oriented outcomes in patients with type 2 diabetes? And the AFP cites this specific meta-analysis review published in 2021 in the British Medical Journal to answer this poem question. And the study is the SGLT2 inhibitors and GLP-1 receptor agonists for type 2 diabetes, a systemic review and network meta-analysis of randomized controlled trials. This study would later become the basis for the BMJ rapid recommendations, which is what is used for the current AAFP clinical guidelines concerning the use of these 2 medications in diabetic patients. So the goal of this study was to evaluate the benefits and harm of these 2 classes of medications in people with type 2 diabetes with varying levels of cardiovascular and renal disease. using meta-analysis of clinical trials with respective grade certainty ratings. There were a few conflicting trials prior to the study, which created some uncertainty about the relative and absolute benefits of these medications in diabetic patients. But the study showed, the study was reassuring in the use of these medications.
I'm having a little trouble hearing with your speaker. There's some static with that.
Okay. Can you hear me now?
Yes.
Okay.
Thank you.
No problem. So a little bit of background on the study, prior study, there were already several large-scale randomized controlled trial studies published in 2015 and 2019 that concluded that SGLT inhibitors and GLP-1 receptor agonists, specifically empagliflozin, which was showed by Zinman in his group, and liraglutide, which was shown by Marceau, both reduced cardiovascular outcomes. And both of these articles were published in the New England Journal of Medicine. However, there were a few conflicting clinical trials, and examples that declare TIMI 58 clinical trial, which was also published in the New England Journal of Medicine. And it concluded that there was no difference in the outcome of cardiovascular death, myocardial infarction, or ischemic stroke between diabetic patients treated with dapagliflozin versus a placebo. This left many clinicians and patients both uncertain of the magnitude of the benefits of both these medications. However, by 2019, major institutes and organizations like the ADA, the ESC, and the NIH released official statements and guidelines, including the use of these two medications in the management of type 2 diabetes. So the researchers used 3 databases to search and identify randomized clinical trials that specifically compared SGLT2 inhibitors or GLP-1 receptor agonists with a placebo, standard care, or other glucose-lowering treatment in adults like metformin. Then 2 researchers then independently screened the studies for inclusion, which included that each study must compare the 2 medications in question, and studies had to have reported outcomes at 24 weeks. Then the 2 reviewers independently extracted the data and assessed the studies for risk of bias. Network meta-analysis was used to compare baseline risk categories. So as you can see in the table, based on the number of risks that the patient may have, they will correspond to a specific risk class, which has a specific recommendation by the BMJ. Okay. And so let me see. So researchers identified about 764 clinical trials. These were further filtered based on the inclusion criteria, as I mentioned before, and this resulted in about over 400,000 patients. So it was a pretty big study. Medications were usually added to a background medication like metformin or insulin. And this is just the median age, sex, A1C starting, and the median BMI was around 30. Okay, so this is a summary of what the researchers found. Both medications were found to decrease all-cause mortality cardiovascular mortality, non-fatal MI, kidney failure. They both reduced weight, although SGLT2 inhibitors had a greater effect on weight, and they both decreased A1C. GLP-1 reduced GLP more significantly than in SGLT2. Interestingly, the SGLT2 decreased admissions due to heart failure, while GLP-1 was found to decrease non-fatal stroke risk. SGLT2 had no effect on non-fatal stroke. GLP-1 is associated with more risk of severe GI events, while SGLT2 is associated with increased genital infection risk. And one major thing that the study found was that absolute benefits for cardiovascular and renal outcomes varied substantially under absolute cardiovascular risk. So depending on the risk category, people that had more, that were in a higher risk category had more benefits to these medications. And this is just the results in more detail. So going back to the poem questions or question, does SGLT2 and GLP-1 receptor agonists reduce patient-oriented outcomes in patients with type 2 diabetes? And based on this study or meta-analysis, the answer is yes. SGLT2 and GLP-1 have reduced both CV and renal outcomes to a greater extent than does placebo. So how can we as primary physicians apply this to our practice? It all depends on the patient or the overall picture of the patient. Higher risk groups tend to have, based on what the article shows, have a greater extent of benefit when using these medications. There are many calculators out there that can be used to estimate the cardiovascular risk. One example that the article uses is the MAGIC evidence calculator. And this article, what was used to form the BMJ rapid recommendations, which was the basis for the AAFP guidelines. So the key point is that if we see a patient that has a high risk for cardiovascular disease or renal disease, to start a GLP-1 or an SGLT2, and given the complexity of our population at FHC, we should, as I mentioned, I kind of mentioned briefly the limitations or restrictions of using these medications, like the cost and tolerance, and also accessibility. And one way to combat these limitations is maybe perhaps talking to pharmacy to see what resources are available to specific patients, or switching to from a GLP-1 that has less GI side effects. AFP guidelines first recommend adding an SGLT2 over a GLP-1 agonist in type 2 diabetes, and that was later brought out later on after this our study was published. So some limitations in that the study kind of faced were there were limitations, the heterogeneity in clinical settings of included trials. All the trials were very different from each other. It was a big trial, but the study found that the data was mostly very consistent, which kind of affirmed the conclusion. Trials generally do not include patients with the lowest cardiovascular risk, so there might have not been as many patients in the lower risk category compared to high risk category. And then A1C and body weight provided in trials had an average follow-up of 6 months. So there was not much data sooner than 6 months. And that may affect the comparison between both of these medications. SGLT2 may have greater weight loss before 6 months. So that's something that could be further investigated.
Moving on to the second article, the second poem. Can you go? The title of that poem was, or the title of that article was SGLT2 inhibitors improve all-cause and cardiovascular mortality in patients regardless of diabetes or heart failure status. So I think that's an important thing to emphasize going into this. It's regardless of diabetes or heart failure status. The question they attempted to address was, what effect do SGLT2 inhibitors have on mortality and cardiovascular and renal outcomes in patients with and without diabetes, heart failure, or kidney disease? And again, this too was a meta-analysis. Next. The methods for this article was there were 2 researchers. They independently searched 3 databases, Medline, Embase, and Cochrane, and abstracts of major cardiology meetings and conferences, looking for randomized controlled trials that evaluated the impact of SGLT2 inhibitors in patients with or without heart failure or diabetes. The breakdown is the requirement for the randomized control studies was, well, first off, they had to be randomized control studies. They excluded observational studies and registries. It had to be an SGLT2 inhibitor versus placebo. The studies had to report pre-specified cardiovascular, renal, and safety outcomes. The follow-up duration had to be a minimum of 6 months. There was no language limitation and no sample size limitation. The population that they ended up with is they ended up with 8 studies, 59,747 patients. So as you noticed, much smaller than Etny's study. 3 studies included patients without diabetes, and 5 studies were exclusively with patients with diabetes. And breaking it down even further, 3 of the studies looked at dapagliflozin, 3 looked at canagliflozin, 2 looked at empagliflozin, and only 1 looked at ertugliflozin. Next. The results for this study were interesting. So treatment with an SGLT2 inhibitor compared to a placebo reduced the risk of all-cause mortality by 16%, cardiovascular mortality by 16%, hospitalization for heart failure by 31%, myocardial infarction by 9%, and composite kidney outcome by 38%. The way they define composite kidney outcome is development of end-stage renal disease, a doubling of the serum creatinine, or any kidney-related mortality. And overall, there is a similar mortality and similar renal benefits for patients with and without diabetes and for patients with and without heart failure. Next. More results. So SGLT2 inhibitor use was not associated with a greater risk of hypoglycemia or amputation. There was no significant effect on the risk of stroke. And among randomized patients, 0.23% DKA events were noted with SGLT2 inhibitor use versus 0.8% with placebo use. And in regards to genitourinary infections, there were 3.3% noted with use with SGLT2 inhibitor use versus 0.67% with placebo. Next. So the conclusions for this article was that yes, SGLT2 inhibitor reduced all-cause and cardiovascular mortality in patients regardless of the presence of type 2 diabetes, heart failure, or renal disease. There were similar mortality reductions in patients with diabetes regardless of comorbid heart failure and patients with heart failure without comorbid diabetes. SGLT2 inhibitors also reduce the progression of renal disease in all of the patients. Next. Notable limitations for this study. This was a meta-analysis. It used published summary data rather than patient-level outcome data. Another limitation I noticed is they use CHF congestive heart failure, but they don't specify heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So they're all just lumped together. There was also a disproportionate number of randomized control styles that investigated each drug. So like I mentioned, there was only one of the randomized controlled trials that used ertugliflozin. And then there was a disproportionate number of randomized control trials with diabetics. There were 5 that were diabetics only, and then 3 included non-diabetics. Next. Overall, my reflection and analysis of this poem was that these were very promising results for patients with cardiometabolic and renal disease, which is so many of our patients seen in our primary care clinics. Not just limited to diabetic patients. The article does not discuss the significant cost barrier of SGLT2 inhibitors. Similar to like Etni mentioned, this is a problem for a lot of our low-income patients or underinsured patients. I mentioned that the heart failure they lump together as a whole, but I think investigating SGLT2 inhibitors specifically in preserved ejection fraction patients could drastically change the way we treat HFpEF in the future. Overall, I thought it was a favorable safety profile. I thought the absolute numbers were pretty small. And then, of course, we don't have head-to-head trials amongst different SGLT2 inhibitors. That would be nice, but I think it would be interesting to see different safety profiles amongst the specific drugs in this class of medications. Next.
So how can we, some changes that we can make to our practice? We can routinely evaluate for the need or use of a GLP-1 receptor agonist, especially in type 2 diabetes with cardiovascular or renal disease. Also, just keeping in mind that we should also keep in mind the absolute benefits from SGL2 and GLP-1 depends on individual cardiovascular risk of the patient.
I also think that in our clinics, we need to routinely evaluate the need for the use of an SGLT2 inhibitor in almost every patient. So especially patients that have cardiometabolic or renal disease, not just our diabetics. I think we can capture a lot more patients that would benefit from SGLT2 inhibitor use. For example, I think some of us, on our EMRs use dot phrases, and for our diabetics, make sure they're on a statin and are they on an ACE if they're hypertensive. We could also use little reminders for ourselves to evaluate if they are on an SGLT2 inhibitor. I also think this is a good opportunity to work closely with pharmacy teams when these cost barriers do arise, given the mortality benefits. So I think it's worth the extra effort to work with our pharmacy and our pharmacy team because the mortality benefit for these patients is so great. It's definitely worth it.
Okay, so this is just a summary of the presentation. So we went over how GLP and SGLT2 inhibitors work. GLP-1 receptor agonists work by binding to a receptor, which activates cascade of synthesis and release of insulin, delays gastric emptying, and increases satiety. And as we found out, it also reduces the risk of cardiovascular mortality and all-cause mortality. SGLT2 inhibitors work by reducing renal tubular glucose reabsorption, increasing urinary glucose excretion, ultimately reducing the serum glucose with additional weight loss, and also has an antihypertensive benefit. So both medications, as shown by both articles, both lower all-cause mortality, cardiovascular mortality, non-fatal myocardial infarction, and kidney failure. SGLT2 inhibitors were more effective at reducing hospital admissions for heart failure, while GLP-1 receptor agonists were more likely to reduce non-fatal stroke. And SGLT2 therapy results in moderate reduction in all-cause mortality. As I mentioned, CV mortality, MI, and a substantial reduction in heart failure admissions and adverse kidney outcomes. These are references. Any questions?
I know you mentioned that you would avoid the SGLT2 inhibitors in patients with a recurrent yeast infection or yeast infection and UTI. Does it say, for example, if the patient is on the medication and comes in with the UTI or yeast infection, would you stop it at that point, or you would just continue and treat the UTI and the yeast infection?
I don't know the answer to that. I do think you have to take the clinical situation like as a whole in a picture. How uncontrolled is their diabetes, which is going to give you an idea of how much glucose they're excreting in their urine. Was this UTI associated with starting the medication, or is it how long have they been on the SGLT2 inhibitor? Is this completely independent? So I think you have to take the clinical picture in hand there.
Thank you.
I have a question about SGLT2. Like you guys talked about cardiac benefits and decreasing hospital admission. Does SGLT2 inhibitors like play a direct role in like a receptor in the heart, or is it because it's an indirect benefit by controlling diabetes?
I think part of the benefit is from the osmotic diuresis effect that the SGLT2 inhibitor has for it. I think that is what they are leaning to.
Thank you.
Do we have any other questions? I didn't see any in the chat. I do see that Dr. Palacio said fantastic job, but if anybody else would like to unmute or put something in the chat, we'll give it a second here. Okay, well, I'm not seeing anything else and I don't have anybody unmuted. So with that, I did put the link in the chat box. If everybody could please help us out and give Dr. Candelario and Dr. Walker some feedback on their presentation today. And we want to thank them for presenting at this Grand Rounds. And we appreciate everybody for joining us. Thank you so much.
Thank you.
Thank you.